In order to begin with the next session, may I please request our respected chairperson and moderator, Dr. Shoibal Kaur and Dr. Sai Satish, to join the session. We have four speakers in the upcoming session, and to begin with, we will go with Dr. Barnard Prendergast from USA, and all these sessions will discuss a broader area of heart failure in patients with the structural heart disease. It is my privilege of introducing Dr. Barnard Prendergast, who is the chair of cardiology at the Cleveland Clinic, London, and a consultant cardiologist at St. Thomas Hospital, the UK NHS flagship institution. He has been involved in the field of transcatheter valve intervention since the first UK procedures were performed in 2008, and is the principal course director for PCR London Valves, the world's largest meeting dedicated to valvular heart disease. So now we will move on to the presentation of Dr. Barnard Prendergast.
So hello everybody, and thank you for inviting me to contribute to this important symposium. My name is Bernard Prendergast. I'm a cardiologist based in London, and I work predominantly at the Cleveland Clinic in London, a new major digital hospital, an exciting addition to the London scene. And I also work at St. Thomas's Hospital as an NHS consultant. It's a great pleasure to be with you in Kolkata virtually. I was recently with colleagues and perhaps some of you in the audience in Mumbai at the India Valves meeting, which was a great pleasure to meet with so many Indian colleagues. And I'm sorry that I can't be with you in person for this particular meeting. My topic today is to address the combination of aortic stenosis and heart failure, and perhaps conjecture how TAVI makes a major contribution for this specific patient cohort. By way of introduction, we've had a breathtaking journey in the world of TAVI over the last 10 to 15 years, such that the procedure has evolved so quickly and has now superseded surgical aortic valve replacement as the predominant mode of treatment for aortic stenosis. The evidence which has underpinned this progression has now been recognized in international guidelines around the world, and TAVI is clearly the dominant treatment, particularly for patients in their 7th, 8th and 9th decades. We now need to accommodate that experience and look into the future and work out how this fantastic minimally invasive transcatheter technology can truly transform the management of aortic valve disease in a more wider context. So everybody in this audience will be familiar with the bimodal natural history of aortic stenosis, characterized by a long latent asymptomatic period and a subsequent rapid deterioration with high risk of death or heart failure associated with the onset of symptoms. And traditionally, our means of intervention, classically surgery, but more increasingly TAVI, have focused on identifying these patients at the onset of symptoms and intervening as quickly as possible. What I want to argue is that we need to change this algorithm and focus on earlier detection and offering earlier intervention at a much earlier time course in this natural history period. And the reason we can do that is because we now have a technology which is very patient-friendly, which is very safe, associated with the low risk of mortality or major complications, that can be undertaken in 1 hour under local anesthesia and allow discharge from hospital within 24 to 48 hours, namely transcatheter aortic valve intervention. And as I said, it is now time for the international community to really rethink our approach to the diagnosis, detection, and intervention for aortic stenosis in this context. In other words, we need to think, even as interventionists, beyond the technology itself, beyond the intervention, and focus on improved access to diagnostic technology, be it plain echocardiography, or the application of artificial intelligence, the use of biomarkers to predict patients at higher risk, and also facilitating everyday patient pathways to ensure access to the relevant specialist in a timely manner. beyond the intervention, we also need to think about issues relating to the durability of the devices that we're using, the appropriate sequencing of surgical and transcatheter options, particularly for younger patients, and also, of course, the appropriate pharmacological treatment, not only for prevention of thrombosis, but also to look after the left ventricle in the best way possible. Because aortic stenosis is not only a disease of the valve, it is also a disease of the myocardium as a consequence of the downstream consequences of pressure overload, resulting in hypertrophy, which is initially adaptive, but subsequently becomes maladaptive with the onset of diastolic and subsequently systolic heart failure. And that's illustrated by this one case vignette, for example, a patient with asymptomatic aortic stenosis and good left ventricular function with modest elevation of troponin levels and evidence of mid-wall fibrosis on cardiac magnetic resonance imaging. By conventional guidelines, this patient was managed medically and over 1 year developed heart failure with extensive myocardial scarring on MRI associated with doubling of his troponin levels. And despite successful intervention, it is uncertain whether these changes are truly reversible. We therefore need to focus on two scenarios. Firstly, the asymptomatic patient, and secondly, as we shall see, the patient with moderate progressing aortic stenosis and associated impending left ventricular impairment. A number of trials have already published, predominantly in the surgical domain, examining the role of early intervention for patients with severe asymptomatic aortic stenosis. The Recovery and Avatar trials, respectively, both showed positive benefits of early intervention by means of surgery, although the numbers enrolled in these studies were relatively small for true statistical power. That situation is going to change in the coming 2 to 3 years with the publication of a number of important studies. The first on this slide is the EVOLVE trial from the UK, a so-called precision medicine randomized controlled trial that stratifies patients with asymptomatic aortic stenosis according to ECG findings and troponin levels, and then on the basis of CMR findings of mid-wall fibrosis, randomizes a cohort of 400 patients to either early intervention by means of surgery or TAVI, or conventional watchful waiting or standard of care. This trial has now completed recruitment, analysis of 1-year outcomes is underway, and publication is anticipated at the ACC in Q1 2024. In parallel, the early TAVA trial, an industry-sponsored trial from the US, has enrolled over 700 patients in a more pragmatic study design and randomized them to watchful waiting or early intervention by means of transfemoral TAVI. Again, this trial is complete, analysis is ongoing, and publication anticipated early next year. There are other studies ongoing, a Danish National Registry study, the EASY-AS study, emanating again from the UK with a pragmatic design powered by exercise testing stratification. And this combination of studies over the coming 3 to 4 years will truly establish the evidence that we need and potentially open the door to earlier intervention for patients with asymptomatic aortic stenosis. Moving on to the syndrome of moderate aortic stenosis with associated heart failure, we again need to address our conventional understanding that moderate aortic stenosis is a benign condition. This supposition has been turned upside down by important nationwide registry data from Australia, a multi-thousand echocardiographic database demonstrating that patients with even mild or moderate aortic stenosis fare worse than those patients with normal aortic valves. This generates the concept of increased left ventricular work over a patient's journey associated with moderate aortic stenosis. And of course, the cumulative burden of not only moderate aortic stenosis, but also often combined with severe aortic stenosis to result in systemic overloading of the left ventricle with consequent diastolic and subsequently systolic heart failure. Returning to the Australian ECHO database, we can see here that these milder forms of aortic stenosis are associated with significant mortality at 5-year follow-up, with multiples that are not dissimilar to those that we conventionally associated with severe aortic stenosis. An important message to our general cardiological colleagues and those manning our echocardiography and specialist valve clinics to maintain vigilance in this patient cohort and ensure early referral for consideration of intervention. Again, we have accumulating evidence, this multi-center collaborative study, for example, demonstrating in the context of heart failure patients that the addition of patients with superadded moderate aortic stenosis is associated with adverse outcome over 5 to 6 year follow-up. And these observational data are shortly to be translated into randomized controlled trials, as I shall shortly summarize. Because we recognize that the excessive burden on the left ventricle is not only associated with left-sided heart disease. The sequence of left ventricular dilatation resulting in mitral regurgitation, pulmonary hypertension, and ensuing tricuspid regurgitation and right heart failure is well recognized by experienced clinicians and a syndrome that we need to eradicate from our clinical practice. So this concept is being explored in 3 randomized controlled trials currently, addressing the role of transcatheter aortic valve implantation in this clinical setting. The TAVR Unload trial has completed its enrollment of 300 patients and is due for publication in 2024 or 2025. And subsequently, the Progress trial and Expand trials being run by colleagues in the United States and Canada will be exploring similar randomization, but in larger patient cohorts. These trials will encompass conventional endpoints, mortality, heart failure, and explore the potential for new treatment pathways, which incorporate not only our conventional clinical parameters, but also newer echocardiographic parameters and those related to the measurement of important biomarkers such as BNP and the use of advanced echocardiographic parameters such as global longitudinal strain and the incorporation of magnetic resonance imaging endpoints. Finally, I want to address the important question of TAVI in the context of cardiogenic shock, arguably the ultimate manifestation of heart failure. We know from our clinical practice that many of these patients present very late in the natural history of their disease with decompensated heart failure, pulmonary congestion, and impending shock. These patients are often elderly and comorbid and are frequently managed conservatively in the absence of any perceived benefit of intervention. Even with balloon aortic valvuloplasty, often our ceiling of care, outcomes are very poor, with mortality at 30 days of up to 50% and at 2 years of 90%. Enter the prospect of TAVI in this setting, a simple low-risk procedure which can be performed via transfemoral access, but is currently often denied to patients in this setting because of perception of poor clinical outcomes. Indeed, in international registries, less than 5% of TAVI recipients are treated in this particular context. And this topic has been addressed importantly in a recent publication in the European Heart Journal that myself, Simon Redwood, and Tiffany Patterson at St. Thomas's and Cleveland Clinic addressed in a European Heart Journal accompanying editorial. In this study, using the resources of the STS-ACC TVT registry, patients with cardiogenic shock were extracted from an overall population over 5,000
with the 10
patients. And importantly, technical success rates were very high and associated with very acceptable rates of mortality in this high-risk clinical setting, with an in-hospital mortality of 10% and of 13% at 13 days. Importantly and practically for the interventional community, the complication rates of TAVI in this setting were low and equivalent to all-comer outcomes, And furthermore, outcomes of a 30-day landmark analysis demonstrated that if patients survived to 30 days, then their mortality at 1 year was equivalent to an unadjusted all-comer control group, thereby supporting the conclusion that TAVI is a safe and effective treatment for patients with aortic stenosis who present in the very risky context of cardiogenic shock. So in conclusion, in this short and rapid canter through the field of aortic stenosis and heart failure, I hope I have reaffirmed your commitment that TAVI is safe and effective in all patients across the spectrum of surgical risk. And as a consequence of this development, we now need to think beyond the procedure and think about not only in patients across the lifetime of their journey with aortic valve disease, but also look to newer patient indications for the procedure, namely those in patients with no symptoms but significant aortic stenosis, and those with moderate aortic stenosis, particularly when that is associated with early parameters of diastolic or systolic heart failure. This belief will be supported by the emerging randomized controlled trials that will publish in the next 1 to 2 years, and I predict that there will be important changes in management guidelines as a consequence. The demand that we will need to face as a community is increasing waiting lists for this procedure, increasing demands of patients and their families, which are going to have major implications for our catheter lab resources and very welcome positive implications for the next generation of interventional cardiologists. Thank you for listening. I hope you have a successful meeting, and I hope that this contribution has been of value and interest.
Thank you. And with that, we will move on to the next session.